Hi guys, in today's video I'm going to talk to you about headaches. The reason I'm going to talk to you about headaches is because it's a really serious condition, there's a lot of differentials and you don't want to miss any serious condition. On a bonus side, it's a really common medical student exam question and medical students often struggle as to which diagnosis is the cause. If you stick around to the end of this video, I'm going to give you a really nice story that has actually happened to me when I was a medical student about a patient who had a headache. Hi guys, my name is Mustafa, I'm a doctor in 911 Hospital. What we're going to talk about is important points in a focus history and to never miss any serious diagnosis and red flags. So in today's video we're going to cover tension headaches, migraines, cluster headaches, we're going to touch on meningitis, subarachnoid hemorrhage, giant cell arteritis and idiopathic intracranial hypertension. Obviously we're not going to go into details, but we're going to give you classic histories about how these patients present so that you never get a question wrong and most importantly, never miss one of those diagnoses in real life. So in terms of a focus history, the first thing that you want to know is when did this headache start and the progression of the headache. And what I mean by progression of the headache is, for example, if you ask a patient from the time this headache started to the moment it became its worst, how long did that take? Now, if this took minutes or hours, you can definitely rule out subarachnoid hemorrhage. But if a patient tells you from the moment it started to the moment it became its worst, that was a few seconds, that's called a thunderclap headache. So it's a subarachnoid hemorrhage. Other important sides, is it bilateral, is it unilateral? What's the character of the headache? Is it kind of a tension type band, a pressure feeling, or is it a pulsating, pounding feeling? And most importantly, what is the severity of the headache? Is it a 10 out of 10 pain or is it a 1 out of 10 pain? Now in terms of red flags, or you could even call them associated symptoms, does the patient have a fever or does he have symptoms of fever? So for example, feeling cold, sweaty, shivery, and does the patient have a rash, specifically a non-blanching rash? Does he have any signs of meningism? And we'll talk about that later. Does he have any nausea and vomiting? Does he have any photophobia or phonophobia? Does he have any tearing or a stuffy nose? And does he have any vision loss or jaw claudication? Let's talk about our first headache. So the first headache is a simple one. It's called tension headache. And what a tension headache really is a headache that every single one of us has probably had. It's a headache you usually have at the end of the day. It's probably associated with stress or dehydration. And it's this kind of pressure feeling in your head. It's both sides of your head, or a tight band classically described in medical student exams. Now, how do we treat it? Drink some fluids, take some paracetamol or NSAIDs or even aspirin. The next headache we want to talk about is a migraine. Now, what I'll talk about migraines is actually just a diagnostic criteria. So you should have at least 5 attacks of the following. It should be unilateral, as in one side, a pulsating headache of moderate severity, and it should be limiting activity. Usually you'll find that patients often want to go to bed to a dark room. So one of the other associated symptoms is photophobia. People could also be annoyed with noise, so phonophobia. They could have nausea or vomiting, and usually the headache can last anywhere from 4 hours to 72 hours. Now, how do we treat it? We treat it with a triptan, such as sumatriptan, usually oral, or if the patient's 17 or under, you use nasal, with paracetamol or NSAIDs, such as ibuprofen. How do you prevent it? Well, if you prevent it, if patients having lots of attacks, you can use something called propranolol, beta blocker. And if they've got asthma and they can't use a beta blocker, then you use topiramate. The next headache is a cluster headache, and you do not want to get a cluster headache. It's actually described as one of the worst headaches you can get. It's described as this stabbing feeling throughout the eye. Patients have associated tearing, and you want to know how painful it is? Usually patients are seen to bang their head against the wall from how painful this can be. They can have a stuffy nose or a tearing of their eyes, and associated things that might happen which are a little bit uncommon is miosis, so a constricted pupil, and ptosis, so a droopy pupil. Now, how do you treat this? Now, common sense is you're not going to give them any tablets, because tablets take about maybe half an hour, 40 minutes to get absorbed. This headache can only last sometimes 15 minutes. So actually how we do it is we give them high flow, 100% oxygen, and if you're going to give something, you're going to give subcutaneous sumatriptan. How do you prevent it? Verapamil is a good drug. The next headache we're going to talk about is actually one of the dangerous red flag symptoms, red flag headaches that you do not want to miss. That's meningitis. So how does that present? Well, it presents with a headache with a fever. And the patient's usually in shock or systemically unwell, as in their blood pressure might be low, their heart rate might be through the roof, and they might have a non-blanching rash across their body. Other things is meningism, so neck stiffness. And a sign that you might hear in exams is called Kernig sign. So in a patient that has a flexed hip, you can extend their knees. We're getting through these really quickly, and if you guys have any questions, please put them down in the comments below. Obviously, we're not going through these in detail. For example, meningitis is a huge topic, and if you guys want me to make a video specifically for meningitis, then just leave a comment down below, and I'll create a video with all the different causes, all the different pathogens throughout the ages, how we test for it. For example, you can look for which cells you want to look for in viral versus bacterial versus TB meningitis. It's a whole different topic that we'll talk about if you guys want me to. The next topic is subarachnoid hemorrhage. Subarachnoid hemorrhage is that one that we described as a thunderclap headache. So when you ask a patient, you ask him from the moment the headache started to the moment it became its worst, how long does that take? Well, that takes seconds. And I learned this from one of my consultants when I had my medical job. It's usually described as the worst headache of their life. And usually there's also signs of meningism, so they can get neck stiffness, they can get photophobia with this, and some patients might present with loss of consciousness. How do we treat this? Well, you need a CT scan immediately, and after the CT scan's ruled out any other causes of raised intracranial pressure, then you can do a lumbar puncture 12 hours later to look for something called xanthochromia. The next headache is something that's called giant cell arteritis. Now, giant cell arteritis is a medium or large vessel vasculitis, usually affects the ophthalmic artery. It presents with a headache in patients over 50 and signs of jaw or tongue claudication and scalp tenderness. So you'll feel they're very tender along the temporal artery. Some patients might have vision loss, and that can be in many forms. Usually it's a transient vision loss, which could last seconds. However, if an optic nerve gets affected, long-term damage can happen, then you can probably get a central scotoma from it. What other uncommon presentations are there? Well, you could get other nerve palsy, such as CN3 palsy. So I actually saw this in one of a patient that had a cranial nerve 3 palsy. We actually thought it was an aneurysm. That's another cause of headaches that we're not covering in this video, and it turned out to be giant cell arteritis. So how do you treat them? You want to give them high dose steroids, and it totally depends on how severe the giant cell arteritis is. It's a different dose if there's vision loss, it's a different dose if there's claudication, and it's a different dose if there's none of these, usually a lower dose. We can talk about that later if you guys want me to as well. Finally, we come to the end of the video, and it's the last headache that I want to talk about. It's idiopathic intracranial hypertension. This usually classically happens in a female who's middle-aged, who's a little bit obese. They present with morning headaches that get worse throughout the day, and they could present with signs of raised intracranial pressure, such as a false localizing sign like a CN6 palsy, a cranial nerve 6 palsy, which is the abducens nerve. And how does that present? Well, it presents with horizontal diplopia. So patients will usually see images side by side. Other things that we could see on our examination, we could find papilledema, which is basically bilateral optic disc swelling. Now, how do we treat this? Usually the treatment is weight loss and using things like acetazolamide. You could also do serial lumbar puncture, and there's some fancy surgeries out there which I won't delve into in this video. Okay guys, so that's the headaches that I'm going to cover today, and I promise you, if you wait to the end of the video, then I'm going to tell you this interesting story that I saw. Well, I was actually a medical student. I was in 4th year. I didn't know very much at the time, and I was in my medical job. I was doing a night shift, and for once I was actually going to stay behind to do the night shift. And the medical registrar told me, you know, I worry about young patients with headaches, and so please go see that patient and let me know if there's anything wrong at all. And I was like, okay, fine, I'm going to go see the patient, and I'm going to just go through my headache history that I've just told you right now. So I went over, and the patient is actually asleep, and he's with his mum and I think his brother and another person. And I asked them, has he been asleep for a while? And they're like, oh, he's just resting. And I was like, okay, how long has he been asleep for? And they're like, a couple of hours. And I was like, have you not tried to wake him up? And they're like, no, we just didn't want to wake him up because he's been tired and just, had a headache all day. He actually lost consciousness before. And I was like, oh my god. I tried to wake the guy up, and he's just not waking up. I assessed his GCS, and he had a GCS 3. And at this point I actually panicked. I was like, oh my god, this guy's probably had a bleed. And I went to the registrar, and she straight away, she was actually incredible. She did it really, really well. She called 3 teams at the same time, and at that time I was like, why is she doing this? She called the anesthetics team, because it's GCS is 3, and if someone has a GCS of 3, or actually 8 and less, then they need to be intubated, because they could lose their airway and die really quickly. She talked to the neurosurgeons, because she knew this was going to bleed, and she talked to the radiologist and got an emergency CT scanner. And we wheeled the patient right to the CT scanner, and I was like sweating. At that time, she was also like, put a cannula in him. And I think I'd only put a couple of cannulas in patients before, and I was like, oh my god, I'm going to have to put a cannula in this patient. It was terrifying. It was actually scary. It was like an emergency, and she was like, put a cannula, it's your job, you've seen the patient. And I got it in. I was very lucky, so it's good. So that's my story. Never miss a headache. Headaches can be serious, or they can be nothing. So I hope you enjoyed this video. That's just everything I'm going to have to say about headaches. If there's anything you want me to talk about in more detail, any diseases, anything I've not covered, it's probably things I missed, like for example a third nerve palsy, a painful third nerve palsy, or fancy stuff like a carotid dissection. then let me know and I'll talk about it. As always, please like, subscribe and ring the bell so that you can see more of these videos. I hope you enjoyed the video today. Thank you.